Well, no, I thought for the sterile.
So you guys, can you guys see it? Thank you. I'm sorry, I'm not. You can see it's kind of like the size of a quarter, right? So you go right in the middle. So what can you do with this? And you'll see in your checkup and your paper, if you have an order, you can get a lidocaine, the topical lidocaine. So if I'm gonna go with my patient, I'm gonna access the line. You can actually put the lidocaine, and then you put a plastic like a Tegaderm, and leave it there for like 30 minutes to an hour, so that it can numb the area. Okay. So even though it's like the first, layers of the skin, it hurts, you guys. There's some patients that's so used to it that they're fine with it. But if you have that order, please use it. Just go put the lidocaine on the patient and leave it there, and then it'll be better. The same steps: you wash your hands, you sterile fill, all of that stuff. If you have to de-access, I think that the first part of it was like if you have to remove the needle, if you have to remove it from the patient. Same thing, you gather your supplies, you come to the patient, they're gonna have the Huber needle. Oh, here it is. Well, I'll do it at the end after I de-access it. So let's say I'm gonna put it in, so I put the lidocaine, I remove the Tegaderm, I clean it really well, and then I start prepping my field. I got everything ready, my chloro prep. This will be like this. This will be like this. So I would clean it with a chloro prep, and you see the Huber needle is. You want to hold your Huber needle like this, kind of like this, because it's gonna go in 90-degree angle. Her eyes are like. So and you want to be careful with this. You want to hold it too. I mean, you clean the area. There's a nice drape that just exposes the chest right here. And go ahead and get that done. You want to talk to your patient, then you remove it. You see how the bevel, it's actually the other way. Bubble. So you grab your fingers, right? And then you are going to locate. You want to palpate. Oh, I got it. Like it's here. You're going to go right in the center. And then ask, like if you want they want the needle to be like this, placed this way, because you're gonna tape it to the outside. So that really matters to the patient, because sometimes they keep it for days. Okay, so then I'm gonna insert it down. You're gonna go 90-degree angle, and then you go down. It's a quick thing, and then you fill up. Okay, and then once it's in, okay, you felt it. Okay, and then once it's there, you're going to, it stays there. Okay, so you can attach the syringe here, and you open it up. You are going to look for blood return. You're gonna look for blood return. Once you get the blood return, you're gonna flush it, with the 10 ml down. Once it's flushed, it's in place, it's patent, it's there. And then you're gonna put a cap or the tubing, like hook it up, and you put a dressing here. You're gonna apply a bio patch, and then you wanna put a Tegaderm in place, and it'll stay there for as long as the patient needs it. It looks painful, right? But if you do it with the lidocaine, it won't be as bad for the patient. So you wanna do it like I said. When you tape it, you wanna tape it away from the patient. The dressing is pretty similar, guys, and you wanna put skin barrier and then your dressing. Okay. So let's say I'm gonna remove it. You check the placement. You probably gave a treatment. You flushed it, and it's all good. Now you can also have the patient take pain medication. So, and then you're gonna be ready. You're gonna have a gauze, and you're going to hold. You're gonna hold the medi port, and then you're gonna pull out, and it's super quick. Oops, and you're super quick, and then you apply pressure. You can apply pressure for about 2 minutes. It'll be, good. And then you make sure you confirm the bleeding is controlled, and then you can put a Band-Aid, and then that's it until the new access.
I think there was.
Did I miss something?
Did you talk about heparin?
I told them according to their protocol.
This is probably one of the ones left in the inpatient where we do put heparin, everything else no anymore.
Yeah,
but-
it's according to the protocol, even like the hep lock, the regular IVs, we used to always hep lock it, we call them hep locks, but now they're saline locks.
Yeah.
So according to protocol, if it's a patient that's an anticoagulant, they might say no. If it's a patient that's okay, they might say yes, okay, or they might say like 3 mLs only. So make sure you follow your institution's protocols, or the doctors, if the doctor has done something, customized on your patient, then follow that.
Sometimes you might have to talk to the oncologist, because it'll depend on when it's gonna be accessed. If they're having treatment like 2 hours after they leave, probably not, but if it's